Welcome everyone to the eMedica MRCGP AKT revision, high yield revision webinar number 3 for the July exam. So in terms of the format, we're going to go through 15 exam style questions covering key topics, followed by rapid reviews. You'll see examples of different styles of questions. We're going to sort of split into 3 parts. So part 1, we'll do 5 questions where you'll have 55 seconds to look at the question. Then I'll launch a poll. Once you see the poll, you've got 10 seconds to select an answer. Then we'll go through the answer, explanation, and teaching. Part 2, we'll do a timed mini-mock exam. So you'll do 10 questions, one after the other. They'll automatically move forward every 55 seconds. Just want you to get used to what does the optimum pacing feel like for standard timing in the exam. After we've done all of those, then we'll go through the answers and explanations. And then part 3, we'll talk about revision planning. What should you be focusing on in these last sort of 7 weeks or so between now and the exam? And then there'll be a dedicated Q&A at the end. Use the chat to get involved in the comments or discussion. If you've got a question that you'd like myself or the faculty to answer, please use the Q&A, not the chat. Questions won't be picked up from the chat. And joining me today on the faculty to help answer questions and deal with queries from the core eMedica team, we have Masouda Rahman and Tuba Jamil. Great, so let's make a start. We're going to go straight into question 1. You've got 55 seconds, and then I'm going to launch a poll. Here we go. Okay, great. So the split is between option A, C, and D. And the most popular answer is A, that the hearing in the right ear is mostly in the normal range. So any question with a picture, make sure you look at both the picture and look at the scenario. So if we look at the picture, we've got a red line and you've got a blue line. You'll notice that this has got circles, this has got crosses, there's nothing with brackets. And then on this side, the age of the patient, that could be useful if you think about common hearing problems that might impact different age groups. So this is a 38-year-old engineer, and they're having an annual check as part of their work. I think, what kinds of thing might need someone to have an annual check that included hearing? So the correct answer is A, that the hearing in the right ear is mostly in the normal range. So well done, that was the most popular answer. Okay, so one of the things you notice is that the ears aren't labeled here, and that's because that's what's being tested here essentially. So in standard denotion, when you have a color audiogram, the right ear will always be in red. Easy way to remember it, refer red, refer right. Okay, so this is the right ear, and then the left ear is in blue. So this is the left ear. So you can see in the right ear, this is anything above this line here, 20 decibels, is normal hearing. All right, and you can see most of what's been tracked, even up to here, they're at the line or better. So they've got normal hearing. You can see they've got very mild loss at very, very high frequencies. This is sort of above, we're looking at like 6.5, 7 kilohertz. They've got very mild loss. Whereas if you look at the left ear, you can see there's, loss even at the low frequencies, and then quite significant loss once you get above 3 kilohertz. It's much, much more significant. Okay, so you see the hearing in the right ear is mostly in the normal range. Now let's look at the other 2 popular answers. That C, that is a conductive hearing loss in the left ear. If there were conductive hearing loss, you'd see brackets showing bone conduction. Both of these are air conduction in the right ear, air conduction in the left ear. That's because in a sensory neural hearing loss, which is what this is showing, they generally don't bother showing the bone conduction because we're not interested in it. In a conductive loss, they'll show you the bone conduction, which would be normal, and you'll see that the air conduction is reduced and there's a gap. I'll show you what that looks like in a minute. And then the other popular answer was D, that again, a conductive hearing loss in the other ear, but this isn't a conductive loss, all right? So bone conduction will always be shown by brackets, B for bone, B for brackets, okay? So either square brackets or triangular brackets. Typically, they'll use, either one of those, but it's always brackets. So here's an example of a conductive loss that's bilateral. So you can see the right ear, you've got these red brackets, the left ear, you've got these blue brackets, and this is the bone conduction, and you can see it's normal. Then you've got the air conduction, and you can see it's reduced in both ears, but you can see that the right ear is probably a little bit worse than the left ear in this example. So this is an example of bilateral conductive loss with one ear being slightly worse than the other, all right? So there's a gap between the bone conduction, which is normal, and the air conduction, which is reduced. So think about what causes a conductive loss, like a big effusion, for example, or a cholesteatoma, something slowing down the air conduction, okay? And then this is another example of a sensory neural hearing loss. This is very typical of presbycusis, the hearing loss of old age. And so what you see in that typically is that the higher frequencies are lost. It's often bilateral, as shown here, okay? And they don't bother showing the bone conduction. Remember, the right ear is always red, the left ear is always blue, okay, when they use color. Move on to question 2, men's health. It's a big spread of answers. Now, this is an example of what we call a two-step question. And you can also see it's a really quite long question. So, there's a lot of lines of text. So a two-step question. The question's asking about the management option that's most suitable, right? But that's the second step. The first step is to look at this description and think, what's a likely diagnosis? And actually, in a different question, you could get the same scenario, and the question could be, what's the single most likely diagnosis? So let's double our learning and let's answer that question too. Type into the chat, if the question was asking, what's the single most likely diagnosis, what would be the right answer? So if you type that in the chat, I'll give you a few seconds to do that. And then we'll look at the diagnosis and we'll look at the management. So things that we've got: epididymal orchitis, prostatitis, torsion. Those are the sort of different options, okay? So if we look at the scenario, the correct answer here is D. Treat with levofloxacin 500 milligrams once daily for 10 days. This fits with epididymal orchitis, okay? Now, you can see if you get the diagnosis wrong in a two-step question, often it will lead to getting the management wrong, all right? So let's look at some of the things that lead us to think about this. So this patient's 52. They've got a 4-day history, pain and swelling, unilateral, okay, right scrotum, and it hasn't changed much. NSAIDs help a little bit. No trauma, that's useful. And then this is very relevant. Recently had treatment for a UTI, not been sexually active for a month, and there's mild tenderness on one side. And this is a really important part. The Pren sign is positive. Type into the chat, what is Pren sign? How would you go about doing that examination? So Pren sign is when you elevate the testes by elevating the scrotum, and then it takes the pain away. If the pain is relieved by elevation of the testes, that's Pren sign positive, and that makes it more likely that it's epididymal orchitis. Whereas if it was torsion, Pren sign would be negative. It makes no difference to the pain when you elevate the scrotum. The pain does not go away. In fact, in a lot of cases, you see, this is another clue that there's mild tenderness. What's the way that tenderness would typically be described for torsion? It would be exquisitely tender, very severe tenderness, right? If they even let you examine it. Other things to think about, torsion, clue can be the age. You can get it in any age, but it's much more common in younger patients compared to someone this old, okay? Now, in terms of the causative organism for epididymocarditis, it could be an enteric organism. That's more common if someone's had a UTI, for example, or it could be related to STI. Which one's more likely for this patient? Well, look, they've not been sexually active for some time and they've recently had a UTI. So that's more likely. And that's why this is a better fit. Okay, like E. coli. So that's a good fit. Levofloxacin 500 milligrams. All right. Whereas you can see if you thought it was torsion, that's why some of you might have picked A. All right. If you thought of an STI, and think about which STIs are common, then you might have thought about some of these other options that are there. And then some of you that picked ofloxacin, the key thing, it's not that ofloxacin as a drug is incorrect, it's reading the whole thing. Remember, doing well in the exam, you've got the knowledge base and you've got the technique. Ofloxacin isn't a single dose treatment. You need to give it over a series of days. That's why C is incorrect. It's not the drug that's wrong, it's the dose. Okay. So epididymocarditis, how can it present? Gradual onset over usually, a period of days. You've got pain, tenderness, usually unilateral. There's a palpable swelling, erythema, and then Pren sign is usually positive. So you elevate the testes, the pain gets better. Now, if a patient had really severe symptoms or they were highly febrile, systemically unwell, and you thought they were septic, you might need to admit them. But otherwise, most of them will manage in the community. So either refer to GU clinic if they can be seen within 24 hours, or if we can't get an appointment that quickly, we can treat it in GP. And you treat it based on the likely cause. So if you thought it was an STI, you thought it was, gonorrhea, for example, often people have chlamydia associated or as a risk. They can think about ceftriaxone, doxycycline, azithromycin, things like that. If it's more likely that it's an enteric organism, are you related to a UTI, lower risk for STI, then you've got options of either ofloxacin or levofloxacin. Do you see ofloxacin, 200 milligrams, it's twice daily, but for 2 weeks. And levofloxacin, 500 milligrams once daily for 10 days. So this is why, if we go back to this option, that this one is incorrect, that single dose. Okay, it's incorrect. And then if we just go over some of the other options, if you thought it was torsion, then, so if you had a younger patient maybe, and if it was exquisitely tender, and if Pren was negative, that would lead more likely to it being a good fit for torsion, then the right answer would be A. Okay. If you thought that an STI was more likely for this patient, so no history of UTI, recently sexually active, then you might pick B. Okay. If this was written down as twice daily rather than a single dose for 2 weeks, that would also be a valid option. Okay, question number 3. So I'll stop you there. The two most popular answers are A and B. No antibiotics or delayed script. They're the two popular ones. Now, there's another two-step question. It's about management according to the fever pain criteria. So the first step is working out the fever pain score. Again, that could be a question. So let's work on that. Type into the chat, what is this patient's fever pain score? So we've got option of 1, 2, 3. Someone's put 2 to 3. You can't, you got to commit, okay? 2 or 3. Which one do you think it is? Someone else has put 4 and someone else has put 0. So we've got ranging from 0 at the low end to 4 at the high end, okay? So this patient's fever pain score is 3. And that's why the correct answer is offer a delayed script for Pen V. Now, I want to go through the knowledge side, but then something really important in technique about this. So first of all, let's look at fever pain. Why did they get a score of 3? Well, the fever part in fever pain, if we go in order of the letters, the fever part is fever within the last 24 hours, and that includes a measurement they've taken at home. So you can see the fact that it was 38.1 earlier in the day, even though they're afebrile now, that's still enough to get a point because within the last 24 hours. So that's the fever part. Then the P is pus. Okay. There's no pus, so they don't get a point. So far we're on 1 based on fever. A is attend rapidly. So attending within 3 days of it starting. They've attended within 2 days, so they get a point for A. I is inflamed tonsils. Look, they're inflamed. They get a point for that. So that's 3. Okay. And then the N is no cough or coryza, i.e., you don't have cough, you don't have runny nose, those kind of symptoms. If you have either one of those, you do not get a point for the N. Okay. But you see, they've got a runny nose, so there's no point for the N. So this patient's fever pain is 3. And so what the guideline says, 2 or 3, delayed script. Okay. Offer a delayed script. That's why B is the right answer. Now, here's the bit I want you to be aware of. So first is the knowledge base. You've got to know things like this and then be able to read carefully. Easy to miss the fact that they've got a runny nose, or knowing the fine detail, that the fact that they're afebrile now. Sometimes people think, oh, there's no point for the fever part, but that it's fever within 24 hours, and that includes one measured, at home. So the fact that it was 38.1 early in the day, they get a point for that. So there's that. But then there's the other bit, which I want you to remember, that you need to answer the questions not based on emotions, but based on the knowledge and the guideline. So let me know in the chat, is there anyone that just, it got your hackles up, this word here, demand, and you think, oh, when someone demands it, you naturally feel like, I don't want to give it to them because they're demanding it. But just because the parent is being demanding, if the child has got a probability that it might be bacterial, you shouldn't deny them the right care according to the guidelines because you don't like the way that someone asked. That can happen, can't it? Okay. Sometimes you get someone and the patient, the way they ask, they're demanding. What if, that patient is actually really unwell and they need antibiotics? That's something to remember, okay? That, look at the actual thing with logic, okay? So fever pain, you get 1 point for each of these. So fever within the last 24 hours, that includes, one that's been measured at home. So even if it's normal now, anytime in the last 24 hours, if it was raised, that's a point. P is pus on the tonsils or the back of the throat. A is attending rapidly, so within 3 days from the onset of symptoms. I is inflamed tonsils. And then N is no cough or coryza. So if they've got a runny nose or they've got a cough, you do not get a point for the N. So score 0 or 1, very low probability that it's bacterial, don't give antibiotics. 2 or 3, there's a sort of higher probability that it could be bacterial, particularly we think about strep, okay? So consider a delayed script. And 4 or 5, there's a high probability that it's bacterial. You should think about starting antibiotics today. If they've not got any allergies, if you're going to give antibiotics, first line is Pen-V for 10 days. If they've got penicillin allergy, then you can use either clarithromycin or erythromycin. Both of those are a 5-day course. Okay. Let's move on to the admin domain, access to health records. Okay, great. So for those of you that were on our full day AKT course recently, this will be a revision, okay? For those that haven't been on that, this might be a topic that you haven't covered yet, so you might be less familiar with it. So key thing here is that this patient isn't looking to access their own records. They're looking to access records for their father who's passed away. And you can see they've got a legitimate interest. They're the next of kin and the executor of the will, and they're worried about negligence and want to take legal action. So if you want to access someone else's records who's passed away, and you've got a legitimate reason to do so, you need to apply under the Access to Health Records Act 1990. So E is the correct answer. Okay, and well done. That was the most popular answer. All right. The second most popular answer was C, the Data Protection Act. What would you use that for? You'd use the Data Protection Act if you want to access your own information. You can't use this one to access someone else's information. You can see he wants to access information about his deceased father's record. So some key bits of health records legislation that you should know a bit about. The Data Protection Act 2018, this is what most people would use, or the most common one that's used. This is what patients use if they want to access their own information. And if you put in a request to access your own information, that's called a subject access report or subject access request. Okay, they are the data subject. If a company wanted to access information about their employees in relation to occupational health, then there's the Access to Medical Reports Act 1988. And if someone wants to access records of someone who's passed away and they've got a legitimate reason to do so, so they're the next of kin or the legal executor of the will, and they're worried about negligence or something like that, then you apply under the Access to Health Records Act 1990. That's what this case was about. Okay, let's look at some data interpretation. This is real life data I've pulled from Public Health. Okay, great. I'll stop you there. So it's asking for the worst mortality rate for women under 75. So the first thing is to read carefully. Worst mortality. The higher the mortality, the worse it is. So if you reframe the question in your mind to make it easier, you're looking for the area that the highest mortality rate, the highest number. These are deaths per 1,000 people. Okay, for women under 75. And then if you look here, we've got persons, that means male and female. You've got male, you've got female, and this is mortality. Whereas you can see here, this is mortality specifically for cardiovascular disease. This is a subset of this data. So making sure that you look at the right line, i.e. mortality for all causes for female, that's what mortality rate means. It means for death for any reason. Whereas you can see, this would be cardiovascular mortality. It's only specifically for deaths related to cardiovascular causes. So once you've done that, all you're looking for is the highest number in this line. And so look, 324 deaths per 1,000, that's Doncaster. All right, so well done. That was the most popular answer. The second most popular answer was Bradford. So why might people have picked Bradford? Common reason people might have picked Bradford is they looked at mortality, but they're looking at men. So in Bradford, that was worse. It was higher than Doncaster. Or they looked at male and female. Again, it was higher. Or they looked at female. So they picked up this bit, women under 75, but they were looking at cardiovascular disease rather than all cause. And if you look at cardiovascular disease specifically, can you see that Bradford and Barnsley and Calderdale as well had worse mortality rates compared to Doncaster. Doncaster actually, apart from East Riding of Yorkshire, which was better than any of them, is actually better than those other three. So that's the common reasons why people might get this wrong. And this is an example of the newer style data interpretation question where they're using real life data from public health. It's not maths. There's no calculation here. It's just being able to interpret the data. So other kinds of data you should get familiar with, prescribing data, regional disease incidence and prevalence, public health data for different formats, regional but practice level data as well, mortality rates, subsets, infant mortality, cardiovascular mortality, all-cause mortality. But also, you need to also be familiar with the graphs and charts that are common in research papers. So interpreting that. And examples of things. So this is an example of looking at demographic data. What percentage of patients in different age groups for a particular practice? Here's an example of antibiotic prescribing, looking specifically at broad spectrum antibiotics, which is often used as a quality marker for a specific practice in England. It's called a quinary graph. These are in 5-year age bands, and you've got male and female data. This is infant mortality data. Okay, and then in terms of research, so this is an example of a leaf plot, which looks at how your pre-test probability will be impacted by the outcome of a result. This is called a Kate's plot, which is a visual way to represent risk. Okay, all of these will be covered in detail at our half-day stats course. Okay, which those of you on the Past Country program, we've got that coming this weekend. Right, any questions on that so far? Type into the Q&A and the team will pick that up. But just to let you know, for those that aren't already part of one of the programs where it's included, if you wanted to join our AKT Masterclass webinars, so the learning is in the style we've just done. So these are live webinars. You get access to the recording afterwards, or you can just subscribe to the recording, where we have interactive learning. You do question to time, then I go through the answer explanation. We look at the techniques, why you might have got it wrong. And after one question, we might actually cover several topics. So, we'll cover 45 questions at each one of these webinars, but we might cover 60 plus topics. Okay. So we've got half-day stats this weekend in the morning, half-day admin, again this weekend in the afternoon. And then next week, 2 long evenings, High Yield Clinical Grammar 1 and 2, 7 hours between them. So 3.5 hours each one. And they all follow that format. All right. So you can book them individually, or you get a big discount if you book all 4. So stats will cover all of these topics and more. And many people have found stats goes from being the thing that they really didn't like or was most feared, or one of the things that they've always struggled with, to one of the things that they ended up getting 100% in, or 85% in, or 95% in, or 90% in. We can really help boost your overall score. Similarly, admin will cover all of these topics and more. And again, lots of people have gone on to do really well in admin, 95, 95, 95, 90 in admin, 95. Had several people get 100. And then the High Yield Clinical Grammar 1 and 2, what we cover are the clinical topics that examiners mentioned in their examiners' reports in recent years. These are things that are often tested again and again. So all of these are covered. And on the second one, we cover a lot of picture tests, because that's often an area people struggle with. Okay. And again, lots of people have gone on to do really well in the clinical and overall. So part 2 of today, we're going to do a mini mock. You're going to do 10 questions. Every 55 seconds, the questions will move forward automatically. We'll go through answers and explanations after we've done all of them. There won't be any polls for these ones, okay? So first question is beginning in 2 seconds. Here we go. Please write down your answers at home and note down the question number. Okay. Okay, well done, everyone. So, time to go through the answers and explanations. You get 1 mark for each fully correct answer. Okay. So, first one, remember in the exam, you have an on-screen calculator. So, if you need to, you can use a calculator. So, we've got someone who currently taking modified release 120 milligrams twice daily of oral morphine, and they're well controlled. But the reason we changed them to syringe driver is they can't swallow now. The oral medication is no longer safe, right? So the most suitable dose is C, 80 milligrams over 24 hours via a CSCI, is continuous subcutaneous infusion. That's how syringe driver is given, isn't it? It's given subcutaneously and over a continuous period. So why is it 80 milligrams? Well, let's do the maths. 120 milligrams twice daily means that their total oral morphine use at the moment is 240 milligrams. Okay. When we're converting from oral morphine to diamorphine, you divide by 3 to put it into a syringe driver. So 240 divided by 3 is 80 milligrams via a syringe driver. So common mistakes is that people often, what they do is they see 120, they miss the twice daily, so they know the conversion is 3:1, but then they will end up picking 40. And then the other common mistake is people don't know the conversion and they divide by 2 and they get 60. Dividing by 2 would be if you were using not diamorphine, but if you're using morphine via injection. So morphine via syringe driver is twice as strong as oral morphine, but diamorphine is 3 times. So that's why the correct answer is C. Okay. So if you're going to, put someone onto a syringe driver, it can be very useful near the end, as part of terminal care. What you do is you calculate the 24-hour oral morphine requirement, including any breakthrough doses. And then if you're converting to morphine via an injection, you divide by 2. If you're converting to diamorphine, you divide by 3. Okay. So you can see they were on 240 in total. So converting to diamorphine, you're going to divide by 3. If you're converting to morphine, you divide by 2. It'd be 120. For those of you that missed that it was 120 milligrams twice daily, you can see then you might have been using this. That's why you might have got 60 if you were thinking of morphine, or 40 for diamorphine. All of those would be incorrect, right? So the correct answer was 80 because it was 3 times. Okay. Okay, so now remember that extended matching questions come in sets. You can see this is genetics 1 of 2. It's the 7th question we're doing today, but it's genetics 1 of 2. That means the second one in the set, these answer options will be the same options, but the question will be different. So what's the question here? What's the risk that these parents who are both carriers for hemochromatosis, what's the risk that their children have the disease? Not that they become carriers, but they have the actual disease. So first part of this is knowing how is hemochromatosis inherited? Type into the chat. What's the mode of inheritance of hemochromatosis? It's autosomal recessive. So if both parents are carriers, the risk of any of their children having the disease is 25%. So C is the correct answer. Now, the second one in the set, same family, but their question now is, what's the risk that, like us, our children become carriers rather than having disease? Okay. So what's the risk? 50-50. Okay. So if we go through autosomal recessive inheritance, if both parents are carriers, so look, mum's got 1 hemochromatosis gene, 1 normal or healthy gene. Dad's got 1 hemochromatosis gene, 1 normal or healthy gene. That's why they're both carriers, right? Remember, sometimes carriers will have milder symptoms, okay? Sometimes they won't have symptoms, they just carry it, and, it's the risk that they pass it on. But if someone's unlucky because you get 1 from your mum, 1 from your dad, if they get the hemochromatosis gene from mum and from dad, you can see 1 in 4 chance, 25%, that they'll have 2 abnormal genes and they'll have full-blown disease. There's a 50-50 chance you either get the hemochromatosis gene from mum or dad and get a normal gene from the other one. You see, 50-50. And then there's a 25% chance that you're fortunate, you get the normal gene from mum and the normal gene from dad. You are no longer a carrier and can't pass it on. Okay. So for autosomal recessive, And this would be the same for, other autosomal recessive diseases, like, for example, cystic fibrosis, okay, or albinism, okay. If both parents are carriers, there's a 50% chance that the children become carriers, 25% chance that they're affected, full-blown disease, 25% that they're healthy non-carriers. And I've listed here the modes of inheritance. It's worth knowing this for some of the relatively more common or important diseases, for the UK population. Okay, now, again, this is a two-step question. This challenging question for two reasons. First of all, it's a multiple best answer. You can see if a question doesn't say how many answers to pick, there's only one right answer. But in a multiple best answer, there's more than one right answer, and they will always clearly state how many options you need to pick. And so it says which two. So you've got to pick two, but you've got to get them both right to get the mark. If you get one right and one wrong, you get nothing. Okay. And then this is also challenging because it's negatively framed. It's the only one we've done that's negatively framed. Most questions in the AKT are positively framed. They ask you, what is the diagnosis? What would you do to manage this? What is the right test? But you might get a few questions that ask what wouldn't be recommended, what you shouldn't do. And if you miss that, you could have the knowledge, but lose a mark because of technique. So first thing is, looking at this, what do you think we're actually trying to do a workup for? What is that we're looking for in our workup? What is the suspected diagnosis that we're looking for? Any thoughts? Because the question could give you these presentation, and then you could ask, what do you think is the likely diagnosis? What might we're looking for? So what you'd be looking for is, look at the age. They're 38. Erratic periods. 6 weeks, sometimes 7 weeks, sometimes 8 weeks, but then no periods at all for 3 months. Then they start back again. Mood changes. No medications. So what we're worried about is premature ovarian failure. Premature ovarian insufficiency is the other name for it. Okay. So which two would not be recommended as part of the diagnostic workup for this patient? The correct answers are A and H. Okay. Given they've got no red flags and, like no change in weight, for example, there isn't an indication to do a pelvic examination for this patient. And it's not recommended to do anti-Mullerian hormones, AMH. Now, what often happens with this question is most people pick H, but they don't pick A. They pick one of the other ones. And so then you get no mark. There are no half marks in the AKT. If you get one right and one wrong in a multiple best answer, unfortunately, you get nothing. Okay. So first of all, why would we suspect premature ovarian insufficiency? Well, look at this patient's symptoms and look at what the guideline says, that when to suspect it. Under 40, not on the pill, and they've got menopausal type symptoms. So, the fact that they've had some mood changes, for example, sometimes they might have some of the vasomotor symptoms, so like hot flushes, night sweats. Sometimes they might have erratic periods. They might stop for a while, then restart. Some of the things that you do initially, first thing is to look at the FSH. You're looking for it to be raised 30 plus on 2 samples, taken at least 4 weeks apart. And then other things that you might do LH, estradiol, prolactin, TSH, testosterone. But the guideline specifically says don't routinely perform a pelvic examination and don't use AMH testing as part of the diagnostic workup. Okay, question number 10, admin domain. So here, again, we're asking for which two, and this is about GMC guidance. So, you've been given a £25 gift voucher. Family member really happy with the way that, you looked after their mum in their terminal phase. So which of these statements are correct? Correct answers are B and F. Again, you need both to get the mark. Multiple best answers are challenging. So unsolicited gifts from patients or relatives may be accepted in some situations. We'll look at what those are, and that the GMC doesn't set any maximum value. So again, a common mistake, people pick E. And that's because what they're thinking about is GMS. GMS is General Medical Services. It's one of the 4 NHS GP contracts. And doctors that work in a GMS practice need to abide by the GMS contract regulations. And part of that is that gifts with a value of £100 or more need to be recorded in the register of gifts at the practice. But this question is about GMC guidance. The GMC doesn't state any value, that's a maximum, nor do they state anything about reporting. That's specifically to do with the GMS contract, which is not what this question is asking about. So again, reading carefully. So there's knowing the difference between GMC guidance and GMS contract and reading carefully, because sometimes people miss that. All right, so it's B and F. So let's look at when can we accept unsolicited gifts. So what the GMC says about gifts: don't encourage gifts, don't pressure anyone to make donations, even if it's to a good cause like a charity. Don't alter the management that you offer or the services given based on gifts. Don't accept a gift if it might be seen as a conflict of interest. And don't accept a gift from someone with dementia. They might feel they have to give it to you. They might feel, oh, I have to pay. They might, someone really elderly might remember a time before the NHS when people did used to pay to go to see their doctors. Okay. But if none of those apply and the gift is given freely, then they can be accepted. And the GMC doesn't state any maximum value or anything about reporting. Whereas if you happen to work in a GMS practice, within that contract, remember, that's nothing to do with the GMC. That says that if you accept a gift worth £100 or more, you need to record that in a register of gifts and keep that in the practice. Okay, back to clinical. So number 11, here, what's the most appropriate next step? Well, you've got this patient with persistent synovitis affecting small joints of hand and feet. What might we be thinking about? Rheumatoid, right? So because it affects the small joints of hands and feet, this is one of those situations where they need a very urgent, within 3 working days result. Don't wait for test results. Okay. Whereas anyone with suspected rheumatoid should get referral within 3 weeks. But there's some categories that should be within 3 working days, i.e., they're increased risk. So what are those? Small joints of the hands or feet affected. That's this patient. Multiple joints affected, or they've already had symptoms for 3 months or more by the time of presentation. They're likely to already have significant disease progression. So any of these, 3 days. Anyone else with suspected rheumatoid within 3 weeks. And you shouldn't delay the referral while you wait for the bloods. You can do the bloods, but don't wait for them to come back before you do your referral. Alcohol. So what we've got here, there's 2 ways that we could calculate this. But something subtle here in terms of reading carefully the technique is how many glasses of wine does this patient drink in a week? 9, right? Because sometimes people just see the 7. You know, if you're in a rush, you could easily make that mistake. But if you look 7 nights a week, they have a large glass of wine. But on Saturday and Sunday, they have another one at lunch because they're not working. All right, it's the teacher. So do you see there's 9 there. Now, there's 2 ways to approach this. So one is if you know how many units roughly are in common drinks, and you know that a large glass of wine, a fairly standard strength for wine, about 12%, if you know that that's 3 units, then you can just do 9 glasses times 3. 9 times 3, 27. Okay. The other way, if you want to be absolutely accurate, is to use the formula. So the formula is that the number of units is the volume in milliliters multiplied by the percentage alcohol by volume. Take that total, divide it by 1,000. It's going to give you the same answer. So look, 250 milliliters multiplied by 12% alcohol by volume. If we take that total, show you on a calculator, okay, 250 mils multiplied by 12% alcohol by volume, 3,000. Divide that by 1,000, gives you 3 units. Okay, so that's 3 units in each glass, and then there's 9 glasses, so 3 times 9, 27. So the correct answer is D, 27 units. Common mistake, people miss that it's 9 glasses in total, and they think 7, so they get 21. The other one is people neither know, either they don't know how many units are in a glass this size, or they don't know the formula, and so then they just have a wild guess. So this is how many units are in common drinks. So wine at about 12%. Now, wine could be much stronger than this, much weaker than this, but at about 12%, a large glass, which is 250 mils, is 3 units. A small glass, 125 mils, 1.5. If it's, much lower, much higher, use the formula. Beer, standard strength beer, somewhere between 3.5%, 4%. A pint of that's about 2 units. Premium beers and lagers, somewhere between 5 and 6%. Pint of that's 3 units. Spirits, 25 mils, sometimes described as a single pub measure or a single shot of any spirit at 40%, which is the most common strength of spirits sold in the UK, is 1 unit. And then cider is often strong, like premium beers and lagers. A pint of cider is usually around 3 units. But if it's a non-standard, if you want to be absolutely accurate, use the formula. So unit is volume in milliliters multiplied by the percentage alcohol by volume divided by 1,000. Now, as part of that, some important knowledge that you need, because they might not give you the units, they might not give you the volume in milliliters. They might tell you how a patient will give you a history. Patient might say, I have 3 pints on a Friday night and 3 pints on a Saturday night. I don't drink the rest of the week. So now if you're going to, they might give you how many percent by alcohol. They might give you that in the question. But how many milliliters is in a pint? You'd need to know that to be able to do the calculation, right? So type that into the chat. How many milliliters is 1 pint? Because we use weird units in the UK, right? We use imperial units. Be easy if things were like, a liter, half a liter, that's easy. There's 568 milliliters in 1 pint. Okay, so I'll just type that into the chat for everyone to see. 568 milliliters is 1 pint. Okay. Good. Question number 13. So got this patient now. You can see that their control isn't great, despite the fact that they're on metformin, agliptin, and aglitazone. So triple therapy already. And the HbA1c is really not well controlled, is it? Type into the chat. At what level do we start thinking we need to add some other treatment? We need to go up another step. They're not well controlled. What's the level of HbA1c? 58. Okay. So 58 and above, if someone's on multiple drugs, is when we start trying to improve. What's the target? 58 and above means it's really poorly controlled. Do something about it. But what's the target if someone's on multiple drugs, like this patient? Target's 53. If they're on multiple drugs or drugs associated with hypos, 53. So you can see they're way above target. That's why now, look, we already tried triple therapy. What's the next step? Next step would be to put them onto an intermediate basal insulin dose or twice daily insulin dose, like NPH, neutral protamine hagedorn. Okay, and continue the metformin. Could stop the others. So very common regime. So NPH insulin is an intermediate acting insulin. So commonly what we'd do is they carry on their metformin in the day, start them on a once daily, given that in the evening, because they've got some cover. This gives a baseline cover, and then they've got some additional cover in the form of their metformin in the daytime, and then you see how they get on. Some patients, that's not enough, so you could do twice daily, so once in the morning with the insulin, once in the evening, and continue their metformin. Okay. Other options, if the HbA1c is even poorer control than this patient, if it was 75 plus, you might go straight to NPH and a short-acting insulin. So this has a baseline, and then short-acting insulins, like around meal times. You might think about long-acting insulins instead of intermediate. So long-acting things like detamir or insulin glargine, these are long-acting. If you've got a patient who can't do injections on their own, they need help, and so like they've got a carer coming in, so you want something that's only going to be once a day. Or if they get recurrent symptomatic hypos, so there's increased risk there. And then it's important that they monitor their blood sugars, typically monitor twice a day, so that you see, do they need to actually go on to, adding things around meal times. Okay, so type your answer into the chat. Okay, so this is part of the evidence-based practice or stats domain, right? There's an example of a free text question. Free text questions, there are no options to guess from. There's no A, B, C, D, E. You would type your answer using the keyboard on the day of the exam. So in this case, type it into the chat. So the correct answer is 41,560. Any other answer, you won't get the mark. These are marked by the computer. Okay. So let's go through the calculation. First of all, what's the question asking? The question is asking for incidence of COVID-19 per million people from this data. So what we care about is the cases. These are the number of cases picked up in 2020. Okay. The number of deaths is irrelevant to calculating incidence. Whereas if they ask for COVID-related mortality, then we'd care about this number, right? Okay. Now, incidence is the number of cases, number of new cases divided by the population. Now, once you've done that, that gives you the base number. But incidence is always reported as per something. So you can report it as percent. Percent just means per 100 people, because cent means 100. That's why there's 100 cents in a dollar. why there's 100 centimeters in a meter, right? Cent just means 100 from centurion. So in this case, can you see it says per million? Why? Because remember during the pandemic, you'd see comparisons on different countries. So the WHO was collating data from all countries, and they had it all reported per million cases for standardization. All right. And so if it's not percent, if it's percent, it's multiplied by 100 in the last step. If it's per thousand, you multiply by 1,000. If it's per million, you multiply by a million. Then the last step, it says to the nearest whole number. So look, let's go through the calculation. So the first bit is the incidence. Number of new cases, 2,770,000 divided by the population. We've got that there. That gives you this number, 0.04156. But you see, because it says per million, you need to multiply by a million. Take this and multiply it by a million, you get 41,560.39. And it says the nearest whole number. So to round to the nearest whole number, what you do is you look at the first number after the dot. If this number is 5 or above, this would go up. So instead of 41560, it'd be 41561. If this number is 4 or lower, then this stays as it is. That's why it's 41,560. So that's the answer. Now, if you put 41,560 per million, you'd get the mark. If you just put 41,560, you'd get the mark. If you didn't include the comma, you'd get the mark. All of that's fine. Okay. But if you put anything else, you wouldn't get the mark. So some of you, some people have, rounded down even further, 40,000 or 50,000. You wouldn't. Those of you that sort of, the most common mistake is instead of multiplying by a million here, people multiply by 100. If I multiply this by 100, I'd go 1, 2, and they would put 4 down. It's 4%, okay? 41,560 per million. Question wasn't asking about it as a percentage. It was asking about it per million, all right? So incidence is the rate of new cases of a disease. So you can either report it as a percentage or as any other proportion of the population. Even a percentage is a proportion of the population. It's per 100, okay? So 1% per year means 1 in every 100. Whereas if you had something like 0.002%, that's not easy for people to put their head around. So you might say that in whole numbers as 2 per 100,000. So, take the number of new cases divided by the population. Then if you're going to turn it into a percentage, multiply by 100. If you're going to turn it into per anything else, multiply by that. Per 1,000, multiply by 1,000. Like mortality is usually given per 1,000. Per million, multiply by a million. Per 100,000, multiply by 100,000 in that last step. Okay, and then the last question was about prescribing in pregnancy. And this is something common, that they will often test knowledge about important drug safety alerts, which are put out by the MHRA, the Medicines and Healthcare Regulations Agency. So the correct answer here is D, that based on recent data, previously, what did we used to say? We used to, it's long been known that in the last trimester, so roughly 28 weeks onwards, we used to say, don't use NSAIDs, contraindicated. But latest data suggests actually 20 weeks onwards, we should avoid using it. And if anyone has used it for significant times after week 20, that we need to monitor them more because of increased risks, okay? So what are the risks? Premature closure of the ductus, renal dysfunction in the fetus, prolonged maternal bleeding time, so then that can increase risks of hemorrhage after birth, and inhibition of contractions causing longer and more difficult or challenging labor. So, drugs to avoid, whether it's oral or injected, it's a class effect. So NSAIDs generally, ibuprofen, naproxen, diclofenac, okay? And this latest data, which led to this drug safety alert being put out last year, was that actually prolonged use of NSAIDs from 20 weeks has shown similar things. It's long been known about in the last trimester, okay? So what they say is that, it could, alongside these things, that, prolonged use, it can also increase the risk of having reduced fluid, oligohydramnios, okay, because of the impact on renal function, and constriction of the ductus, which can lead to heart problems. And so if anyone's been exposed for several days at 20 weeks or more, we need to do additional monitoring. And we should avoid prescribing and advise, expectant mums to avoid buying over-the-counter NSAIDs from, for the whole second half, basically, 20 weeks onwards. So that's gone earlier Previously, it used to be 28 weeks, the advice. So add up your score. You get a total out of 15. 11 or more would be at a pass. 10 would be borderline, i.e. in some exams, it would just be below the pass mark. In some, it would just be above. 9 or less, you're not there yet, but don't worry. Your exam's not tomorrow or next week. That's why we're going to talk about how to make the best use of these last 7 weeks. And whatever your score, what you want to look at is the marks that I didn't get. Is it knowledge? Is it, part of the curriculum that I haven't covered yet? Or is it technique, in which case I'm going to learn from that and I'm going to apply it in the rest of my learning? So, at this stage, you should have already covered a good chunk of the curriculum. What you want to do is systematically cover all of the rest of the key curriculum topics. And then any weaker areas that you find challenging, that you're still not doing as well in, you want to revise them again. And you also want to revise your stats, your admin, your high yield clinical again. The last 30 days before the exam, we will post a video each day in the GP training support group. You can follow that. It'll also be on our YouTube channel. And you want to have a big focus alongside this reading to cover the gaps is working on exam technique. So you should be doing questions every day. As you get closer to the exam, try to do a timed full mock each of the weeks, the last few weeks leading up to the exam, and some mini mocks to time to get you used to managing your time. That's why we did that 10-question mini mock. Okay. So in terms of covering the curriculum, for those of that have already got our curriculum checklist, make sure that, between now and the exam, you've covered all of them. Our high yield topic checklist, make sure that you go over these topics more than once. And for those that haven't already got some of these resources, if you want to look up a specific guideline, you can use the NICE guidelines or the NICE CKS. If you want to cover lots of them efficiently, you can get hold of our clinical case cards. So the latest edition has just been published, 2024, 112 topic reviews. There's a digital edition, there's printed physical cards, and there's a bundle that includes both, okay? But they're up to date as of 2024. And then if you found that way of, the way that we did, like 10-question mini mock, if you found that helpful, our AKT 200 mock grammar course is coming up on the 1st day of June. So in that course, what happens is we learn through doing a lot of questions and going through a lot of rapid reviews, but you do them in the format of mini mock. So you do a 50-question teaching mock, 50 questions, one at a time, just like we did it, one after the other, automatically moving forward every 55 seconds without any polls. And then we go through the answers, explanations, and teaching for all 50. You get a topic review, with the teaching slides. Then we have a break, then another 50, then lunch, then another 50, then an afternoon break, then another 50. So a really long day, 9 a.m. till like 6:35 p.m. But by the end of that day, we will have covered over 200 topics in one day. We will have done 200 questions in the right proportion of the exam, i.e. 80% clinical, 10% stats, 10% admin. And then you follow that up with another full 200 question online mock with 200 different questions to continue your revision. Okay. So just to recap the things that are coming up, and someone had asked about discounts. So all of these bundles are automatically discounted. So I told you earlier about the AKT Masterclass bundle. So that's our stats half day, admin half day, that's running this weekend. The High Yield Clinical Grammar 1 and 2 running next weekend, long evenings. All right. So there's over 12 hours of learning. If you were to buy these all separately, they'd be 448, but they're 299 if you get them as a bundle. Our AKT Booster bundle includes that and the 200-question grammar, which is the full day at the beginning of June, and another online mock. So over 25 hours of learning. That's 495, save over £200 compared to buying them separately. Then our AKT Pass Plus bundle includes all of that and the full day AKT course that ran last week, the recording of that, the AKT Masterclass, which is a half day, the recording of that, 2,700 online questions, including 3 full mock exams, and it includes our clinical case cards. Okay, so that's our AKT Pass Plus. So, that's an even bigger saving. I leave you with this message. Coming up to, this last 7 weeks now, this is the time to intensify your studies. And it's important, don't count the days, make the days count. That's what Muhammad Ali said, that, especially actually as you get to the last month, every single day, make sure that you're doing some questions, doing some reading, revising something you've already covered before, that you're making some progress, okay? Don't let a single day get away from you that you're not ticking off some boxes on that checklist, that you're not making some progress towards your goal of passing that exam. Because if you make every day count, then you've still got a tremendous amount of time to really make a dent, make a huge difference to the progress. And all of that hard work and that sacrifice will pay off when you get that big green tick, when you get the results. That if you put the work in and you put the effort in, if you can consolidate your knowledge and work on your exam technique, you will be prepared and you will succeed.